So at this juncture, I'd ask someone to unmute and remind us what we talked about in enzymology when we were talking about the different types of inhibitions. How are they working? And how are they being overcome if they were being overcome? So in enzymology, what were the types of inhibitions and what was the mechanism behind those inhibitions? Once we answer those questions, it will be very easy to cover drug antagonists and agonists. As we said yesterday, the two are kind of similar. How drugs interact with receptors is similar to how substrates will interact with their enzymes. So someone kindly to unmute and tell us about the inhibitions in enzymology.
Okay, so there are 4 types of inhibition. The first one is competitive inhibition, where the inhibitor binds to the active site where the substrate binds. To overcome that inhibition, you just have to increase the concentration of your substrate. In this one, the Km increases while Vmax stays the same. The second one is non-competitive inhibition, where now the inhibitor binds to an allosteric site on the enzyme. Here the Vmax decreases while Km stays the same. The third one is uncompetitive inhibition, where the inhibitor binds to now the enzyme substrate complex. So the enzyme and the substrate have already bound, forming a complex, and now the inhibitor inhibits that complex. Over here, both the Km and the Vmax decrease. The last one is irreversible inhibition, where now the inhibitor binds covalently to the receptor, and it doesn't, even if you increase the substrate concentration, it will not go back. It's not reversible. And over here, the Vmax decreases while Km stays the same. Yeah.
Thank you so much, Hiral. That was a nice overview. And yeah, essentially, that is what we'll just be repeating here. Actually, now that Hiral has mentioned it, we won't be repeating it that much. But yeah, competitive, the substrate and the inhibitor, they kind of look the same, and they bind to the same active site, but non-competitive, they bind to a different site. And then when it's irreversible, it means they formed a covalent bond, and then you need the substrate can't be binded. All of that, yeah. So I'm sure now we'll be done in maximum in 20 minutes. So we already talked about the 4 types of antagonism. We said pharmacologic is whereby they are acting on the same receptor to bring about different actions. Chemical, here we gave the examples of antacids and acids. Pharmacokinetic is about inhibition and or induction, okay? Then in physiologic, we said they act through different mechanisms to bring about different responses. Epinephrine will act through beta-2 receptors on the lungs. Histamine will act on histamine receptors on the lungs or on the bronchial smooth muscles. Epinephrine will bring about bronchodilation, whereas histamine will bring about bronchoconstriction. So physiologic, different receptors. Pharmacologic, same receptors, different action. Yeah, we already mentioned all that. We won't be repeating all this. Anything we've mentioned, we won't be repeated. So pharmacologic is the main focus of this discussion, but Nani has given us a good overview, so we'll just be skimming through a lot of this. Now, there are two types of ligands on a receptor. We have an agonist and an antagonist. We know an agonist, it mimics the action of the endogenous ligand, right? For example, if we are talking about epinephrine binding to beta-2 receptors to bring about bronchodilation. We also say now albuterol or salbutamol is a beta-2 agonist because it binds to the beta-2 receptor and also brings about bronchodilation. So agonists just they mimic the action of the endogenous ligand. So we'll see one unique thing with agonists is that they have both affinity, meaning they remember what we said about affinity, Jana. Affinity is just this drug likes associating with this receptor. So agonists will have a high affinity to that receptor and intrinsic activity. Now, intrinsic activity is the it's that this drug can bring about a response. Like the drug can induce a response once it has binded to the receptor. But antagonists, they just have affinity, but no intrinsic activity. Essentially, an antagonist just goes and sits on the receptor, but it has no action. It has no further action on the receptor. It just sits on the receptor and prevents the endogenous ligand from coming and eliciting an action. So an agonist has both affinity and intrinsic activity, whereas an antagonist only has affinity. It will just, a beta blocker just goes and sits on a beta receptor and prevents the likes of adrenaline from binding to that receptor. Of course, there are a few beta blockers which we mentioned that they have intrinsic sympathomimetic activity, but those are just a few. But essentially, other beta blockers, they just go and sit on the receptor and prevent binding of the endogenous ligand. So we already described what affinity is, what intrinsic activity is. And now let's see the types of pharmacological antagonism. Competitive, also known as reversible. This is what Hirala has repeated, right? They both will be binding to the active site and will be competing to bind to the active site or to the receptor. Let's say now in this case to the receptor. So if in this case we are seeing atropine and acetylcholine are competitive antagonists, meaning they both bind to the cholinergic receptors. And if the concentration of atropine is more than the concentration of acetylcholine, more atropine will be binded. And the opposite is also true. So competitive, there's nothing much there. It's the same competitive we see in enzymology. Non-competitive or irreversible, again, just a repetition. This is where the drug is binding irreversibly to the receptor, right? And when we say reversibly, we know this is covalent bonding has occurred. Simple as that. The drug binds irreversibly to the receptors. Then partial antagonism or agonist. Now, partial means that the drug, it just from the name, think of it as a partial agonist, or yeah, first of all, let's think of it as a partial agonist. It binds to that receptor, but elicits kind of half the response that a full agonist will elicit. Okay, so it has the affinity is there, but low intrinsic activity. But for a full agonist, they'll have high affinity but high intrinsic activity. Then finally, inverse antagonism. Inverse antagonism. Now, an inverse antagonist is whereby this drug binds to that receptor but acts as an antagonist, but it's unique because this antagonist has intrinsic activity. It binds to the receptor and elicits the opposite response. Okay, it binds to the receptor and elicits the opposite response to that of the agonist. So in our case, the most common type of inverse antagonist is the antihistamines like diphenhydramine. Those, as much as we say they are H1 receptor antagonists, they are in actual pharmacology, they are inverse antagonists of histamine receptors. So antihistamine, your diphenhydramine, once it binds to your histamine receptors, it induces the opposite action of histamine. So if histamine causes you to have a runny nose, this one will cause you to have a dry nose. It induces the opposite action. Yeah, and then some beta blockers. Remember, we're talking about there are some beta blockers with intrinsic activity. So, yeah. So inverse antagonist is just binds but elicits the opposite action. Full agonists, we've explained this when we were talking about partial. Full, we'll see the maximum response, whereas a partial, half the response, or just as the word suggests, a partial response. Yeah. Then an inverse agonist, it's the same terminology here. Binds to the same receptor as an agonist, but will induce a pharmacological response that is opposite to that of the agonist. And for the neutral one, is neutral. I don't want to talk about neutral. That one is a whole other discussion. Then let's move to competitive. We've already said competitive. It's reversible. If you increase the concentration of one nini, then the antagonism is reversed. Simply, yeah, we won't be repeating that. Then for non-competitive or irreversible, again, we said what? There's formation of a covalent bond. Breaking a covalent bond in the body, it's so hard. So even if you increase the concentration of the agonist, you cannot reverse this antagonistic effect. Then finally, we have partial agonists stroke partial antagonists. We've already said these ones, they have affinity, but low intrinsic activity. They have affinity, but low intrinsic activity. So a partial agonist stroke antagonist, like the term is used like that, partial agonist stroke antagonist. So when the agonist is not there, this drug will behave like the agonist, but of course with a low intrinsic activity, with a low effect. But when the agonist is there, this drug behaves like an antagonist. In short, partial agonists stroke antagonists, they're just attention seekers. When the natural ligand is there, they want to fight the natural ligand. When the natural ligand is not there, they want to act like the natural ligand. Yeah, simple as that. Inverse, we already said inverse, it binds but produces an opposite response. Yeah. Then as we finish on pharmacodynamics, drug receptors, that interaction between drugs and receptors eventually can lead to some changes. We know with the long-term administration of some drugs, there is what? There is tolerance. For example, alcohol. Alcohol is a drug, right? With constant use of alcohol, you need a higher concentration of alcohol to elicit the same feelings that you had when you were initially when you initially started drinking alcohol. That is tolerance with long-term use. But tachyphylaxis is whereby it's the same as tolerance, but this one is more of acute or rapidly occurring. Tolerance is over a long time, but tachyphylaxis is over even a few doses of the drug, and already your body is diminishing the response to that drug. So tachyphylaxis is just over a short time. Tolerance over a long period of time. Then dealing with a decreased receptor. The receptor does not respond as much to the agonist, right? Desensitization, yeah. And then refractoriness, you know about refractory period is just a period whereby there won't be any response to the drug, the agonist, the ligand. We'll talk about even refractory period when we're looking at an action potential. And yeah, there's that period between one action potential and that another action potential whereby action potential, that period is called that refractory period, right? That period between which no action potential can be generated.
Guys,
Yeah.
I have a question.
As much as drug resistance, here.
Guys, can you hear me?
Yeah.
I have a question. As much as tachyphylaxis and tolerance are the same, one is rapid and the other one is like over a period of time. But I think like tachyphylaxis, as much as you increase the concentration, it won't make any difference. Right?
Yeah. True.
Because for tolerance, for you to overcome the chronic response, you have to like increase the concentration so as you can increase the metabolism of the drug. But in tachyphylaxis, a small dose can lift it up, so the concentration doesn't matter.
Yeah, that's
true. Okay.
Thank you. Yeah. Yes, so I guess that is, that's it for agonists and antagonists, unless someone has something to add, something to emphasize, or a question. Yeah. Or if there's somewhere you haven't understood, you can just feel free. Okay.
Guys, kuna mwenye amesema repeat the previous slide.
Okay. So here we are talking about drug receptor interaction. We said when a drug binds to a receptor, it elicits an action, and that's how we benefit from a drug. Yeah, but that's not the only thing that can happen. Several other things can happen. The first thing one of the things can be desensitization, whereby the receptor the receptors kind of diminishes, or the receptor has a reduced responsiveness to the drug. Okay, that's desensitization. Okay. The other thing is tolerance. Tolerance we've talked about. With long-term administration of a drug, we need a higher dose of the drug to elicit the same response as it used to before. And a good example for this is usually just alcohol. Alcohol, the first day people start drinking alcohol, within the fourth, fifth drink, they've already started feeling some sort of way. But the more people drink alcohol, they're able to tolerate more and more concentrations of alcohol. So that is because your body has built up a tolerance. We say you build up a tolerance. Your body has adapted to this drug, and now your body is having a diminished response to that drug. But after long-term use, after prolonged use of a drug, and tolerance is also what we see with even when we're talking about this abusing of drugs, people who abuse opioids, and at the end of the day, they end up overdosing. It's because when they were starting off, just for example, heroin, just one injection of heroin, and they were feeling high. But with time, tolerance builds up, and this guy has to inject 3, 4 to still chasing the same high. It reaches a point they have injected up to 5 and they are still not feeling anything. So that's what tolerance is about. Is with prolonged use of something, you need higher doses to achieve the same effect that you used to achieve before. Then refractoriness. For refractoriness, we've said is that period which there is no response to the drug, and we've likened this to the fire in the action potential. There's that period after an action potential, we call it a refractory period, meaning an action potential cannot be generated for a certain amount of time. Another analogy to explain refractoriness is during coitus days. For guys, there's a refractory period. There's a period between ejaculation and there's that time between ejaculation and subsequent arousal. There's that time where after ejaculation, the guy cannot be aroused. That is the refractory period. Then drug resistance. I don't think I need to talk about drug resistance. It's antimicrobial resistance. This is the word these days. Tachyphylaxis. Now for tachyphylaxis, whereby we haven't even given you a high dose. We haven't given you a drug for some time, but we're already seeing signs of tolerance. So for tachyphylaxis, it's sort of acute tolerance. And Shafi has explained further that for tachyphylaxis, even when we increase the dose, we won't see the response to the drug increasing. Yeah. So I hope I've explained that adequately. Karibu. Now it's 10:34. At 10:40, we can start on pharmacokinetics. So pharmacokinetics. Someone jana aliniambia you guys have studied for 5 years, and we don't need to take a lot of time to cover these things that are so obvious. So I'm expecting you guys admit what is pharmacokinetics, and when we talk about pharmacokinetics, what are the 4 parameters that we look at? Nini? Yeah, what do you know about pharmacokinetics? Just unmute and say something.
Okay, pharmacokinetics is the study of the body. It's like what the drug does to the body. So we'll determine the absorption, distribution, metabolism, and excretion of the drug.
Okay, nice. What the body does to the drug, absorption, distribution, metabolism, excretion. Someone else? Someone else. You have the answers, eh? You can't say all you know about pharmacokinetics is absorption. What do you know about absorption? What can you say about distribution, metabolism, excretion? Yeah, not Shafi. Shafi ameongea.
Okay, it's like tracking the drug until it reaches the target. Some drugs, they can pass the fast metabolism, of which it can be metabolized, some of it in the liver, before it reaches the target site of action. So this is how much of the drug reach to the target body site. So it's like tracking the route of administration, all of it. So that's why we say there are some preferable routes, like the local routes, like topicals. When we have like skin infections, you cannot give antibiotics which are systemic. That will not help. Like if someone has a burn or a local infection, so you're supposed to treat according to that. I don't know if I'm making sense. Yeah.
No, you're making sense. Yeah. And again, you've brought another important point in pharmacokinetics, and that is routes of administration. Yeah, routes of drug administration. Now, so anyone mentioned any route of drug administration, an advantage, a disadvantage. No, we don't have to display slides and redo and things we know. Let's save on time.
Oral.
Mm-hmm.
Yeah, so it's the advantage is it can easily administered.
Mm-hmm.
What's the advantage that can? Okay, let me go to disadvantages. There are many. So
Yeah.
some drugs can be they cannot be administered to unconscious patients who are vomiting. Yeah. It also has some of the drugs have a very bitter taste.
Yeah, bitter taste. Yeah.
Yeah. Another disadvantage. That's all I can remember right now.
Okay. Yeah, that's nice. Oral, and it's the most common route, obviously. Yeah. Someone else.
There is parenteral routes.
Mm-hmm.
There's it includes the likes of the subcutaneous injections, the intravenous injections, and the which is the other one? IM intramuscular.
Mm-hmm.
Yeah, some of the advantages can be it can be given to unconscious patients.
Yeah.
Also, it has a fast bioavailability, especially for IV.
Mm-hmm.
And for drugs that maybe you need a long-term effect, you can give them like in IM,
Mm-hmm.
like a depot. Yeah, Some of the disadvantages can be during or rather the reversing if the effect of the drug can be quite I don't know, tricky or hard in case of an adverse effect. The other one is obviously the pain associated with these methods.
Yeah.
Something else. What else? Okay, that's all I have for now.
Yeah, nice. And because it's an injection, we will say that except for the sub-Q, we'll say they usually need a trained provider. The patient cannot self-administer like oral. Yeah.
Also, there is nasal absorption through the mucous membrane. That one, it bypasses the first pass metabolism, and there was I don't remember well, but there was a drug that was used in hemophilia A that can be given also to prevent the bleeding of. Which one is that? I think when we were doing the now when Nani was teaching us Orata, she talked about a drug that was given nasally that's used for hemophilia A. Let me Google it, I'll tell you. I mean, 1 minute.
Okay. Meanwhile, I think desmopressin. Yeah.
Meanwhile, Shafi akitafuta, there's the rectal route.
Rectal.
Advantages, it avoids the fast metabolism. It can be given to patients who cannot tolerate the oral administration. It can be given to unconscious patients. Self-medication is possible. Disadvantages, I think people who have, cannot be administered to people who have like diarrhea. It can cause irritation and then compliance to patients because of ethical issues and culture, religion.
Yeah.
Compliance, there is an issue there. So if guys to be tested for prostate cancer is also an issue.
Yeah.
Any other route? Routes mean you haven't even mentioned 10% of the routes.
Guys, it's gonadotropin releasing hormone agonists. Like they can be used as a nasal agents. And then I think someone typed in the chat.
Someone talk about desmopressin.
Desmopressin, that's the one that's used for hemophilia A. To control the bleeding in patients. See, because I think hemophilia A, it's a disorder of it's a genetic deficiency in clotting factor 8.
Yeah.
So they'll be susceptible to bleeding. So desmopressin, if it's given intranasal, it can bypass the fast pass metabolism, and it's highly effective.
How well are you in How well do you know hemophilia A now that you've brought hemophilia A up?
Oh, that's the only thing I remember. Unless you explain it further for us.
That one we'll cover it when we are covering. Actually, we'll cover it maybe this week when you're doing the cardiovascular diseases. Then so we've talked about the routes. Any other route that you are
sublingual.
Yes, sublingual.
Advantages: avoid fast metabolism, rapid absorption. Disadvantages: irritation, unpleasant taste and stuff.
Yeah, manze, the taste really matters there.
Yeah.
And what's a common drug for sublingual that
Nitroglycerin.
yeah, nitroglycerin. What is nitroglycerin used for?
It's used for, is it cardiac something? Sikumbuki
Yes,
gani.
cardiac, yeah, ischemic heart
Yes.
disease. Ndio, it's a vasodilator.
Yeah.
Yeah, or a venodilator. Venodilator is more correct.
Yeah.
And this
kwa-
thickness inakuwa gani? Sublingual. It's
Gani
the
yo?
name. Yeah, motion sickness.
Scopolamine. Ama
I
gani?
don't know.
Scopolamine is not a patch.
Yeah,
Kuna
I think
moja
it's
ni-
patch.
There's one that is sublingual. I don't know.
Kuna sublingual nitroglycerin.
Uh-huh.
I think it's used for something to do with the heart. Ama?
Yeah.
hiyo ni ya heart.
Yeah, it's used for angina pectoris.
Yeah.
Chest pain.
Yes.
Another route. Mtu akienda operation, if talk about nasal, the one that is related with nasal.
Nitrous oxide.
Isoflurane.
Yeah, what's
And
the route? Well, the route is called?
Hiyo inhalation sijui.
Inhalation or pulmonary. Yeah.
Yes,
Umesema intrathecal,
Yeah, that's another one. Intrathecal route into the CSF.
pia kuna
Vaginal.
Pesa.
vaginas.
Vagina. Hiyo mmemention.
Vaginal.
Intraarticular directly into the joint.
Yeah, manze, yeah, things like rheumatoid.
Yeah.
Yeah.
Urethral.
Sija kusikia Black Panther.
Urethral.
Oh, urethral, yeah. Hiyo ni another unconventional route.
Alafu kuna parenteral route that was given vaccine ya TB, BCG. It's not given in subcutaneous and
Intradermal.
intramuscle. Yeah, intradermal.
Yeah,
Alafu
intradermal.
kuna intramedullary direct to the bone marrow.
Yeah. Hizo routes ni mengi.
Alafu kumbukeni pia buccal route, the difference between buccal na sublingual. Sublingual ni under the tongue, buccal you put it between the gum and the nini.
The cheek.
Yeah, in the cheek.
Yeah. So yeah, that covers it for routes of administration. And now when we're talking about absorption for the let's start with the most common route, which is the oral route. For a drug to be absorbed, should it be lipophilic or hydrophilic? If you want your drug to be absorbed, do you want it to be lipophilic or hydrophilic?
I think lipophilic ndo you pass through the membrane. Inaitwaje? Lipophilic. Hiyo plasma. Inaitwa what membrane? Ulisema jana.
Yeah, exactly. Kwa
Yeah.
lipophilic ndio hii diffuse through the lipid bilayer. Yeah. Then hydrophilic won't easily diffuse, but you want your drug to kind of have both some lipophilic nature and some hydrophilic nature. Hydrophilic so that it can dissolve in your gastrointestinal fluid. When it's able to dissolve, now the lipophilic component comes through for it to be able to diffuse. If it's too lipophilic, it won't dissolve. So if it won't dissolve, it won't be absorbed. If it's too hydrophilic, it will fully dissolve, but it won't be absorbed. So that's why you see drugs being weak acids or weak bases. You know, they kind of have a lipophilic component and a hydrophilic component. Then by what mechanisms are drugs absorbed from the GIT? There are majorly 4 mechanisms through which drugs are absorbed from the intestines. Which are these?
Passive.
Yeah, passive diffusion. Yeah, nice. And that is the major one. Most drugs will be absorbed by passive diffusion.
Active transport.
Active transport, yeah, that's another one. Being transported against their concentration ingredient.
Facilitated diffusion.
Yeah, facilitated diffusion, whereby it's diffusion only that for facilitated, we need to have a carrier channel. And lastly,
Cytosis.
yeah, endocytosis. Yeah, we talked about the forms of endocytosis. Who can remember the forms of endocytosis that we mentioned, Jana?
Pinocytosis, Lathrin mediated.
Phagocytosis.
Yeah, nice. Pino, yeah, Clathrin and Phago, yeah. See. Then there's a particular vitamin we mentioned that is absorbed through Clathrin mediated. Which vitamin was this? Clue is that intrinsic factor is needed. Anyone? Vitamin inahitaji intrinsic factor to be absorbed.
Vitamin B12.
Yeah, vitamin B12. And in what condition do we see there is a deficiency of the intrinsic factor, hence leading to pernicious anemia? Nice, yeah, pernicious anemia. Then we already talked about drug absorption. So when a weak acid is in an acidic solution, will it be charged or will it be uncharged? Or when an acid is in an acidic solution. So let's say I have my HCl in the stomach, and then I've taken aspirin, acetyl salicylic acid, in the stomach. Am I expecting my aspirin to be charged or uncharged while in the stomach?
Uncharged.
Yeah, nice, uncharged. So if it's uncharged, is it more likely to be absorbed or less likely to be absorbed?
The uncharged is likely to be absorbed.
Yeah, exactly. Yeah, uncharged is more likely to be absorbed because it's non-polar. And the lipid bilayer is also non-polar, like dissolves like. Yeah. Ah, nice. We're going good. We're going good. The other thing. What effect does the food have on gastric emptying? Does food increase the time in gastric emptying or reduce the time in gastric emptying?
Reduce.
Reduces the time of gastric emptying, meaning gastric emptying happens faster. Okay, that's in. I will explain. I feel like my English is off. So ukikula chakula, will it take more time for the stomach to be emptied or less time?
It'll take more because I think when you're in a fasted state, maybe the gastric emptying.
Yeah. It will take more time. Yeah, food increases the time for gastric empty. Because umekula, now your stomach has to take things slow, digest, pole pole, until it absorbs. So food slows gastric emptying, or it increases the time for gastric empty. So once you take a drug with meals, you expect its absorption to be slower. Okay, you expect its absorption to be slower, but you expect the Cmax, the concentration in the plasma, to increase because there's more time for it to be absorbed. It's been absorbed slowly, but there's more time for it to be absorbed as compared to when you take a drug on an empty stomach. And then, who remember what the pig glycoprotein was? Pig glycoprotein.
I think it's like albumin, where it's one of the proteins in your plasma where drugs can bind to it. So for pig glycoprotein, I think you have this alkaline or neutral drugs that bind to it, and then for albumin is this weak acids like aspirin, if I'm not wrong.
No, not really, because pig glycoprotein, here the drug is still trying to be absorbed from the stomach. So the
Oh,
pig
it's not the one in the plasma, or?
No, it's not the one in the plasma.
Oh, okay.
Yeah.
So the one in the plasma is called what? Like you have albumin and then it's also
Is
pig.
it the one? Is it the one that's used for xenobiotics, Amma?
Xenobiotics, Ajay. We mentioned it and when in biochemistry and xenobiotics, but now
What I don't know, it was using some ATP, and then I don't know, it was pumping the toxic xenobiotics out of the blood or something.
Yeah, exactly.
Something of that sort.
Yeah, pig glycoprotein it was pumping drugs, toxins out of the cell. So if we are eating,
absorption.
yeah, exactly. Yeah, so the pig glycoprotein, it uses ATP and pumps stuff out of the cell, right? It's expressed in the intestines, in the liver, in the kidney, in the placenta, but essentially it pumps drugs out of the cell. So it reduces drug absorption.
But the one in plasma is called what? Protein binding. Isn't it something similar, or I'm confused?
Alpha-1 acid glycoprotein, which is usually for transportation of drugs together with albumin. Albumin is basic. So for albumin, it will bind to acidic drugs. But alpha-1 acid glycoprotein, it will bind to basic drugs. So it's one of the proteins for transportation or distribution of drugs in the system. It's alpha-1 acid glycoprotein.
Okay, thank you.
Thank you so much. Next. Next we go to bioavailability. What's bioavailability? From your basic understanding, what's bioavailability?
The extent to which the drug is available at its site of action.
Yeah, the extent to which, yeah, and this extent, it's what is it being compared to? Because we express it as a percentage.
Maybe if I would say it's that percentage of drug that reaches systemic circulation unchanged via any route apart from IV. Because remember, when we give an IV injection, we are having 100% bioavailability. But now we are comparing other routes to the IV administration.
Yeah, nice. So in short, it's you've given this patient 10 mg of amlodipine, you test the blood, you see only 7 mg has reached. So bioavailability will be 7 over 10 times 100. It's the fraction that reaches systemic circulation unchanged, right, compared to what you initially administered. That's why in IV it's always 100% bioavailability, because you are injecting directly into the systemic circulation. Yeah. Then now, what are the factors that influence bioavailability? Remember, we're majorly under absorption. We are usually focusing on oral drugs, so we are still under oral route of administration. Factors that can affect bioavailability. So here it's like you also been asked factors that can affect absorption. But even after absorption, does the drug reach systemic circulation?
Half-life.
Half-life. How explain? Kindly explain so that.
Because half-life, it's the time required for the amount of drug to be 50% of the concentration you've given. So, and if you have to attain fully maximum bioavailability, that drug has to stay longer period in the system.
You know, now when we say about half-life, it's as you've defined, it's the time it takes for the concentration of the drug still in systemic circulation to fall by 50%. But bioavailability, we're talking about the drug that is reaching systemic circulation. So in half-life, and half-life is more of now the drug is in the bloodstream. Bioavailability, we are saying before it reaches the bloodstream, what can affect it? What can lead to it either reaching in the bloodstream in high amounts or in low amounts? So half-life is more of the drug is already in blood.
Oh, yeah. How about clearance?
clearance, yeah, clearance now here, yeah, clearance stuff like, yeah, that fast pass metabolism, yeah.
Is it like factors kama
I think solubility in a promoter.
Yeah,
The more the
yeah,
drug,
solubility.
the more soluble a drug is, the better it is. It's going to have a greater dissolution.
Yeah, solubility.
Also, the degree of ionization.
Yeah,
It's
degree of
ionizable or
ionization.
because it affect kama drug itakuwa absorbed ama it's not gonna be absorbed.
Yeah, degree of ionization, solubility, yeah, that is, yeah. These all they are related.
I
Another
think
point.
also the pH would also affect.
Yeah,
depending.
the pH of the medium. Yeah, it will affect if this drug is absorbed. So if this drug will reach systemic circulation.
Nini itakuwa considered ya route of administration or
The route of
if route of
administration. Yeah, because we'll say IV has 100% bioavailability. Oral, it is in the drug. Topical, it's nearly less than 10% bioavailability. So the route of administration does affect bioavailability. Yeah, it's a factor.
Na protein binding iko.
Na sa protein binding unaona nao hapo tumefika kwa distribution. We are kwa the pharmacokinetics, we are still at A. Hatujafika hapo kwa distribution because that is where protein binding is majorly. Yeah.
Na GI transit hiyo.
Yeah, the GI transit time for some drugs that yeah. Because let's say mtu akona diarrhea, then the bioavailability will be low because there isn't enough contact time. Yeah, no, it takes, it's not a must that you kukue any certain points. Then to take you back to anatomy, once a drug is absorbed from the small intestine, and now it's in the blood, do we say that it's in systemic circulation or not yet? And if yes, why? If no, why?
I think you can say it's in systemic circulation, but it still has to go through now that first pass effect from the liver, and then it goes like into circulation to go into its target organ or something. Yeah.
Anyone else with a different opinion? Because people argue about that thing.
I think no, but the explanation would be the same. Because it has to go through fast pass first. So after fast pass, Ndona would consider it like core bioavailable.
Yeah. Because now in pharmacology specifically, when stuff is absorbed, it gets into portal circulation where it has to go to the liver. Then the liver is what will now detoxify any harmful stuff. Then from the liver is now when it enters the main circulation, which is considered in quotes the systemic circulation. So when the drug is in portal circulation, we don't consider that to be systemic circulation. So we can't check bioavailability in portal circulation. That the value we get there won't be correct, because as Hirala said, there is some still aspect of first-pass metabolism in the liver. Remember, first-pass metabolism occurs both in the small intestines and in the liver. So after that drug has left the liver is when you can say, now the first-pass metabolism is over. We can test and say it has this amount in the drug, in the blood, so it has this percentage of bioavailability. Yeah. So then now we can go to the next thing. We've covered A, absorption. We've mentioned absorption. So the next thing is D, distribution. Distribution. Drugs, how are they distributed? The drug is now in systemic circulation. The liver has given its tick. You've given it IV. So in IV, there is no absorption, it's directly distribution. When it comes to distribution, what's one major thing that we always mentioning?
Plasma proteins that bind to the drugs.
Yeah, exactly. Plasma protein binding. Plasma protein binding. Yeah, that's a major thing in distribution. Plasma protein binding is a major thing. So if a drug if we are having a drug being highly bound to the plasma protein, is it available to act on its site of action in adequate amounts if a drug is highly protein bound? Or the
No.
No, yeah, exactly. It's the free unbound drug that works the magic. The bound drug is just bound. But the advantage or something that we can get from plasma protein binding is that the plasma proteins can also act as reservoirs. Reservoirs for the reservoirs for that drug. Yeah. So plasma protein binding, that's the major thing. The other thing is also about the lipophilicity of the drug, right? Lipophilicity. So for lipophilicity, what do you expect about its distribution? Do you expect to find it a lot of it in plasma or a lot of it in the tissues?
A lot of it in the tissue.
Yeah, a lot of it in the tissues. Remember, plasma is hydrophilic. Plasma is water, essentially. So lipophilic, they just diffuse and they enter into the tissues. Yeah, but hydrophilic, they stay. A lot of it, you'll find it in the plasma, right? Yeah. And then second thing, we've talked about plasma protein binding, and then talked about lipophilicity. Thirdly, capillary permeability. Capillary permeability. And I think we answered a question related to this last week when we were revising one of the papers. And we said the liver is one of the places that is highly permeable to anything, and we need the liver to be highly permeable to most stuff. But we get to the brain and we find the brain has that blood-brain barrier. We go to the testicles and we find the testicles have the testicular blood barrier, which is similar to the blood-brain barrier. So are we expecting to find our drug being easily distributed to the liver or to the brain?
The liver.
Yeah, the liver, because the liver, we are having a really high capillary permeability. Even plasma proteins can enter into the liver. But the brain is invite only occasion, you know. But now that we've mentioned the brain, in what circumstances is the permeability of the brain increased?
In diseases kama meningitis.
Yeah, meningitis. Yeah, that's a major one. Meningitis, yeah. And when there's just inflammation, yeah, nice. So usually, even the drugs that we use for meningitis, usually on a normal day, they don't easily permeate the blood-brain barrier. But when you have that infection, the blood-brain barrier is also compromised due to the inflammation. So the drug is able to enter easily. Yeah. Then the other thing is
Also in like
Mhm.
disease states, like for example, in like liver cirrhosis, you
yeah,
expect
in liver
expect albumin to be low, so bioavailability or volume of distribution is higher.
yeah, nice, yeah. When the plasma proteins are low, it means the free and bound drug is high. It means a lot of the drug is unbound. That's why we see hepatic encephalopathy, right? Whereby the bilirubin has entered into the brain because the bilirubin is free. Right? It's not been bound to albumin. Yeah. Nice. Then we've talked about lipophilicity. Then the other thing now is when we are talking about volume of distribution, we consider the body to be having three functionally distinct compartments. Three distinct compartments. The first one is a plasma compartment. The plasma is, we've already said there, we're expecting the hydrophilic stuff to be staying there. And not only the hydrophilic, but the highly protein bound. They are the ones that will stay in plasma. You want it to be highly protein bound, they'll stay in plasma. And then for the second compartment is the extracellular fluid, the ECF. We know the ECF still includes the plasma, but it includes the interstitial fluid. So in this case, we have hydrophilic, but they are not highly protein bound. So it's hydrophilic, but it's not highly protein bound. So it's leaving the what? It's leaving the plasma because it's not been binding the plasma, but it gets into the interstitial fluid and it can't diffuse into the cell because it's hydrophilic. So that's the second compartment, the extracellular fluid. And then the third compartment, obviously now there is the intracellular environment. Yeah, the intracellular environment. Here we're expecting, of course, the lipophilic drugs we already mentioned. Those are the ones that will enter into the cell. Then now just something about the volume of distribution. When something has a large volume of distribution and another one has a small volume of distribution, what does it mean? A large volume of distribution, does it mean the drug is more in tissues than in plasma, or the other way around? So in relation to the drug being in tissue versus the drug being in plasma, what does a high volume of distribution suggest?
High volume of distribution suggests that the drug is more in the tissues than in the plasma.
Yeah. Perfect. Yeah, even okay has also said it. Yeah. Large volume of distribution, it means this drug is going to the tissues. Large volume of distribution, just even from the word, it means this drug is largely distributed. So it's going to the tissues. If it's going to the tissues, so we're expecting lipophilic drugs to be having high volume of distribution. Yeah. Then now we're coming to stating a few questions. Let me see if I can. So what because we've already covered this when we were covering nuclear chemistry, when we were covering chemistry in organic chemistry. We have zero order reactions and first order reactions. Right? Oh, now we are in metabolism. Oh, let me say now we are in metabolism. Now we are entering into metabolism. And so in metabolism, number one, half-life. We already defined the half-life when we were discussing, and we said half-life, time it takes for that concentration of the drug to fall by half. So what's the formula? There's zero order and first order. Now someone can annotate this whiteboard and write for zero order reactions, what's the formula for zero order reactions? And then what's the formula for first order reactions? And from those formula, also write the formula for calculating half-life. Once we've gotten that, metabolism will be.
How do you write in here?
Do you have an option hapo kwa your controls to annotate? Somewhere written annotate.
Okay, I think I can see now. For zero order, no. Okay, why is this thing acting? For zero order, it was.
You can tell me to write for you here. Tell me what to write. Zero order.
Zero order, it was 80 is equals to constant. I think elimination constant.
That's K.
Yeah. Or am I confusing? I don't know. Maybe. Wait, let me check.
Watu wengine unmute. Help.
It was 80 is equals to AO minus KT.
AO minus KT.
Yeah,
Nice. Then now half-life. What's the formula for half-life for zero order?
AO over 2K.
AO over 2K. And then now we have first order. In first order, what's the equation?
Now we add in 80 is equals to in AO minus KT.
It is equals to, and the in is a natural log.
Natural log.
Yeah.
I hope guys you know where the in is in the calculator. You don't need the formula and then on the day of exam, you'll be like, hey, where's the in?
See, it's shift log, Ama.
Yeah, it's shift log. Yeah, someone may be looking for in and they don't find it.
No, it's not that. There's an in.
My calculator doesn't imagine.
I mean, then gonna in.
But
Acha
let
ni-
me take a picture of this and just
Ukiweka shift log, it inakuja like it brings 100. Shift log 2 brings 100 instead of 0.693 for the half-life.
aye. Oh, half-life equation.
Yeah, in 2 over k.
In 2 over k.
0.6.
0.693
693 over 2.
over k.
Okay, yeah.
Yeah. Now, zero order and first order. Now we've written the equations. Now, how do they differ? What happens in zero order and what happens in first order? Based on when it comes to metabolism stroke elimination, metabolism and elimination, they are related. We metabolize so that we can eliminate. So in zero order, we are having a constant amount of the drug is being eliminated per unit time. Whereas in first order, a constant fraction of the drug is being eliminated per unit time. Let me just repeat. Zero order, constant amount per unit time. First order, constant fraction per unit time. So let's see an example. We'll say in zero order, for example, it will be let's say it's a drug such as what? Drugs such as phenytoin. Yeah, phenytoin, this is an example. Phenytoin will say in zero order, when we're talking about zero order, assuming we've given the assumption, this is an assumption. We've given a patient, assumption, patient given, let's say 200 mg of phenytoin. 200 mg of phenytoin. So if it's zero order reaction, zero order, it will be in such that 10 mg of phenytoin is eliminated every hour. This is still an example per unit time, so every hour. But in first order, it's let's say 10% of phenytoin is eliminated every hour. Every hour. So what this means is that if we up the dose to, let's say, 400 mg of phenytoin, if phenytoin is being eliminated by zero order, it won't change. The patient will still eliminate 10 mg of phenytoin every hour. But okay, there's some, we didn't write here. So 10% of phenytoin in the first assumption 10% of phenytoin will be what amount of the 200 mg? 20 mg, right? 20 mg. Let's put in bracket. 20 mg is the 10%. So if we up the dose to 400 mg, we've said in zero order, the patient will still eliminate 10% of, in zero order, the patient will still eliminate 10 mg of phenytoin every hour. It won't change, okay? But in first order, if we've upped the dose, now assumption 2 is 400 mg administered. Now we've upped the dose to 400 mg. In zero order, 10 mg is still stands. But in assumption 2, it's still the same thing. 10% still stands. But now it's 10% of what? Of 400 mg. So in this case, this patient will now be eliminated 40 mg every hour. Because for first order is what? First order is a certain percentage of the drug is eliminated per unit time. So if you increase the dose, the percentage remains the same, but the amount also increases proportional to the dose. But in zero order, it's a certain amount. It's 10 mg. Even if you give this patient 2 grams of phenytoin, they'll still just eliminate 10 mg every hour. Yeah, I hope we've understood that zero order and first order. Now let's go to metabolism. Okay, that was also part of metabolism. But going now to the enzymatics of metabolism. So I asked, why do we metabolize drugs? What's the essence? I take my paracetamol. Why is my paracetamol metabolized? Why does the body metabolize drugs?
I think for some they're converted from the inactive form to the active form.
Yeah, conversion from active to inactive form. Yeah.
And vice versa.
Yeah, and vice versa. Another reason.
Is to make it more polar for excretion.
Yeah, to make it more polar for excretion. Yeah, that's one of the major reason why the liver and other organs will metabolize drugs to just eliminate them. Yeah, but also to activate, to inactivate. Yeah, those two, they are usually together. You can activate, you can inactivate. Yeah, make it more polar. Yeah. So under metabolism, we mention phase 1 and phase 2 metabolism when it comes to drugs. Who can remember what was in phase 1? What were the reactions in phase 1? Or what enzymes were involved in phase 1? And which ones were involved in phase 2? In pharmacology, we always mentioning cytochrome P450. Now, where is this cytochrome P450? Is it phase 1? Is it phase 2?
Phase 2, there is conjugation of drug, like there is glucose. I think cytochrome P450 is phase 1.
Yeah. CYP450 is phase 1. Phase
And
2
then the
is
other phase 2
conjugation.
is the Conjugation. Yeah.
Yeah, glucuronidation, sulfation, acetylation. Yeah. But in phase one, mostly what we are having is oxidation, reduction, and hydrolysis. Okay. But phase two, we are having conjugation. Conjugation is the main thing. Yeah. And now for cytochrome P450, where are they found in the cells? You know, we've talked about the cell, but we've never mentioned where cytochrome P450 family of enzymes, where are they found? In which organelle? Anyone? Anyone? In which organelle?
In the endoplasmic reticulum.
Yeah, in the endoplasmic reticulum. Yeah, that's where they are found. Smooth or rough? If you are, maybe the examiners decided to test you further.
Smooth.
Smooth, yes, smooth endoplasmic reticulum. That's where the CYP family is found. And now, without going into a lot of details, because we'll see all of this, someone can mention a few good examples of CYP inducers and a few good examples of CYP inhibitors. An example of a CYP inducer or examples.
For inducers, you have rifampin, carbamazepine, and phenytoin.
Yeah, nice, yeah. For inhibitors,
It's mostly the antibiotics and antivirals like azithromycin, ritonavir, things like that.
Yeah. Nice. And yeah, because you've mentioned ritonavir. Ritonavir, what is it used for?
HIV.
HIV. Is it used alone or in combination?
In
Does
combination.
ritonavir come on its own?
Combination.
Combination. Usually with what drug?
Like the TAF, TAF.
Yeah, okay. Or rather, if a patient is taking lamivudine, okay, but if a patient is taking ritonavir, lamivudine, tenofovir, those are the nucleoside reverse transcriptase inhibitors. Which class are we expecting this patient is also taking? Because she said that ritonavir is a CYP inhibitor, yet we are seeing it being used in HIV, but it's not used because it's active against HIV. It's not that active. So what is it used for in HIV?
Go ahead, Shafi.
Ritonavir is usually used with lopinavir, and since it's an inhibitor of CYP, it inhibits the metabolism of lopinavir. So it basically increases the concentration of lopinavir.
Yeah, exactly. It's used as a pharmacokinetic enhancer. It's used to increase the concentration of the protease inhibitors. Yeah. because it does have activity against HIV, but it's not given because of that activity. It's given so that it can reduce metabolism of other protease inhibitors. Yeah. Then we've mentioned the inhibitors, the kina antibiotics, the likes of erythromycin, isoniazid, the azole, itraconazole, yeah. Phase 1, we already said CYP 450, phase 2, conjugation. Now, finally, we are in the last step. The drug has undergone all these things. We are now ready to eliminate the drug. What are the 2 common organs involved in elimination of drugs? The 2 organs.
Liver and kidney.
Liver and kidney.
Yeah, liver and kidney. So the liver, where the kidney is so obvious, it will excrete it in urine. Where does the liver excrete its stuff?
Bile.
And how?
Bile feces.
Enterohepatics.
Pardon?
Enterohepatic circulation. Mama?
Yeah, exactly. The conjugated stuff will be needed in bile. And then from bile, it will be released into the intestines. In the intestines, your drug can be lost in feces or it can be reabsorbed. And now I bring you to a question on a patient. Actually, this is actually a true story. A patient was on the H. pylori kit, but the patient was also taking the combined hormonal contraceptive, the oral, and the patient ended up getting pregnant. What happened? What can you explain happened? The patient was on the H. pylori kit, amoxicillin, clarithromycin, and the PPI, but the patient is still taking oral contraceptives. What happened?
The H. pylori kit killed the bacteria in the intestines that are used to recycle, I don't know, something to absorb the estrogen from the COP.
Yeah, nice. Yeah. Estrogen is conjugated in the liver and released in bile, but once it gets in the intestines, the bacteria deconjugates it and estrogen goes back into the blood. But when the patient took antibiotics, it killed the normal flora, so not enough estrogen was deconjugated, hence the efficacy of the oral contraceptive failed. Yeah, nice. Then, yeah, that's it. Actually, that's it. With elimination, the other thing Chai mentioned, if you're having an acidic drug and you want it to be lost in urine, what do you give to the patient? Do you give them an acid or a base? You're having a patient has overdosed on an acidic drug, and the drug is now, you want the drug to be lost in the urine. What will you use? An acid or a base?
A base.
A base. Why?
Because a base will make the drug to become is it ionized or polarized? It prevents absorption.
Yeah.
It won't be absorbed, so it will end up being excreted.
Yeah, true. Yeah. Then now just to make sure you know your stuff, when a drug has a very low pKa, does it mean it's an acid or it's a base? A drug has a low pKa. Is it an acid? Ah, yeah, an acid. Yeah. Then yeah, that's it from me. If someone has something to add, they can add, but essentially that is it about pharmacokinetics: absorption, distribution, metabolism, and excretion.
Yes.
Mm-hmm.
Pardon the explanation for oral contraceptives together with the H. pylori kit.
Janet, it was your explanation. Explain it again.
I think you did it more service, but I'll try to say it in my own words, but you can explain it further because I feel like you used better words. Basically, so in the intestines, you have the normal flora, which basically helps when you take the combined oral contraceptives. The normal flora will help in deconjugating the estrogen. So it is recycled. It's a recycling process. The estrogen keeps on being recycled in your body. But now when you take the medication for H. pylori, it will go clearing the bacteria and lessen the bacteria in your intestines. So in this case, after the estrogen has been conjugated in the liver, since we don't have the bacteria anymore along your intestinal walls to help with the recycling, the estrogen will end up being excreted out. So it reduces the circulation of estrogen in your body. That's why the patient ended up being pregnant, because now the COP were no longer efficacious per se. I hope I've made sense.
So what
Yeah,
gave her the
thank you.
pregnancy? You are blaming the H. pylori kit.
I am blaming the pharmacist for not explaining that to the patients.
Shafi, are you good?
Yeah.
Any more questions, additions? Maybe if you have something to add on pharmacokinetics, now is your moment. Dr. Karemi, Faiza, Laila.
Mine is to say thank you for the nice discussion and how you've led the group and for other members' participation. So I'm grateful. Thank you, guys.
Discussion, it was quite interactive and like when you're using slides.
Yeah. Well, yeah, that's what I was told. I was told you guys have the content. I even saw you guys graduating. You're called doctors. That's why you have the information. Someone is asking a question on the group chat. What are the factors that affect elimination of a drug? What are the factors that affect elimination of a drug? Thoughts.
Maybe to start with, one of the factors would be if you have renal issues like AKI or CKD, you expect the elimination to be affected in a way.
Yeah.
Another factor would be administration of other drugs, which will affect either reabsorption or secretion of the others from the system. For example, someone taking probenecid and amoxicillin, probenecid will increase the stay of amoxicillin because it will inhibit its excretion, or it will enhance its reabsorption back into the system. So it will be either enhancing the elimination or delaying the elimination, leading to the drug staying in the system for a long period of time.
Okay, yeah. She's talked about the organs. If you're having kidney impairment, if you're having liver impairment, we're expecting reduced elimination. She's talked about the presence of another drug that is interacting. A drug may either promote or inhibit elimination. She's given the example of probenecid can be co-administered with penicillins to prevent their elimination. Anything else? Binding to plasma proteins, right? If a drug is highly bound to plasma proteins, it means it will be less eliminated. We know plasma proteins serve as the reservoir. Yeah. Another point.
Urine pH.
Urine pH. Yeah, we'll talk. Yeah, urine pH based on the acidity or alkalinity of the drug. The urine pH will affect elimination. Hence, we've talked about modifying the pH of the urine. Anyone else with another point? Okay, I think those are the points. Yeah. Welcome. So this evening at 5, we'll be doing cardiovascular anatomy and physiology in a nutshell, in the same manner. We've said no more slides, just a few diagrams. So we'll see you all in.
Guys, can I differ? Please, can we have like 2 little slides? Some of us, we are visual, like when we see